So we're going to finish up the cardiovascular system. This is with chapter 21, and we're going to focus on the blood vessels. Recall we talked about blood in chapter 19, the heart in chapter 20, and now we're going to look at blood vessels in chapter 21. So one thing to note is that there are kind of two main types of blood vessels that we focus in on. The first are arteries. Arteries are going to carry blood away from the heart. This means that they are carrying blood to other tissues. Okay, so these are the vessels that are moving away from the heart. The wall of an artery consists of three main layers. The first layer is called the tunica interna. Of course, that's the internal layer. A tunica is like a tunic. It wraps around. This is made of endothelium, just like the endocardium of the heart. We also see that we have the tunica media. This is the middle layer. It's composed of elastic fibers plus circular smooth muscle fibers. This is to allow for stretch in that elastic region, but also the muscles to help push the blood forward or away from the heart. We have the tunica externa, which is composed of elastic and collagen fibers. And again, in this case, it's to allow for stretch and recoil, as these vessels contain high pressure. Now, there are two main types of arteries. The first ones are called the elastic arteries. These are what we call the conducting arteries. They are large in diameter, so they're your larger arteries. They have more elastic in them and less muscle, so that they can actually withstand the high pressure that's going to be coming through. So because of these, they're pressure reservoirs, so they're able to, with that elastic, stretch and be able to go back into that normal size with the high pressure that comes with each heartbeat. On the other hand, you have your muscular arteries. These are the distributing arteries. They're the ones that are going to be smaller, more medium diameter. They're going to have more smooth muscle, fewer elastic fibers, and they're going to distribute the blood to the various parts of your body, okay, to your different internal organs, but also to your extremities and that sort of thing. Now, if you'll take a look at the picture over here, it shows you the different layers. This is going to be important because an artery structure and a vein structure is very similar. However, the layers are going to be different based on like their width and things like that. And so I want you to make sure that you take a look at this. Also, a lumen, when you see lumen here, lumen means hole. So this is the hole that runs through, because remember, an artery is a tube. So the lumen is the opening of that tube. And this picture is found on page 731 in your textbook. Now, when we look at arteries, large arteries are going to go into medium-sized arteries, which then are going to transition into small arteries, which then are going to be transitioning into arterioles. Arterioles are tiny arteries that connect to capillaries. All right, so capillaries we'll talk a little bit more about later, and then they're going to connect to the vein side. Now, many arteries have what we call anastomosis. This is where the distal end of two or more vessels actually merge together. This is a good thing because it allows for an alternate route for blood flow in the case of like if there was a blockage that took place. This alternate blood route is called collateral circulation. Okay, so you can see in the picture over here, you have the one vessel where it has multiple ways that the blood can travel to where it needs to go. In the second picture, it shows you that there's a blockage that's there, but the blood still gets to where it needs to go because there were alternate routes. Arteries which don't have anastomosis, they are what we call end arteries. So if they actually become blocked, the tissue supplied by that artery will start to die because it will not receive oxygen, nutrients, or waste will not be removed. Now, through vasoconstriction, okay, that's the closing up, constriction, and vasodilation, arteries and arterioles play a key role in helping regulate your blood flow, how much blood comes in through the area, and also your blood pressure. If the opening is wider, it's going to allow more blood to come through, and it's going to have less pressure behind it. If we see that it's constricted, less blood's going to come through, but it'll have higher pressure. Now, this is going to be controlled a lot of times by the nervous system. So you have what we call the sympathetic nervous system or sympathetic stimulation. That's going to cause contraction of the circular smooth muscle in the arteries and cause vasoconstriction. On the other hand, the parasympathetic stimulation is going to cause relaxation of the circular smooth muscles and cause vasodilation. Now, these arterioles connect to the capillaries. The capillaries are what we call your microcirculation. They are microscopic blood vessels, so they're super small, can't be seen with the naked eye, and they are going to connect your arterioles to your venules. So they're going to connect the artery side to the vein side. Okay, so the capillary walls are only a single layer of endothelium, and this is important. They are connected to a basement membrane, but the reason why they are a single layer is this is the area where we're going to see diffusion and exchange of substances. So capillaries will branch and merge, forming a network. And this is going to allow for increased surface area so that they can exchange nutrients like oxygen, glucose, amino acids, things like that with the cells and that are in the tissues. But then they can also diffuse and pick up waste products from the tissues like carbon dioxide, urea, any other of those toxins that they create due to metabolic processes. Now, some capillaries are continuous. They have no pores in them. These are known as continuous capillaries. On the next slide, I'll show you a picture of what that looks like, but they're just going to be a smooth layer with no pores or holes in them. On the other hand, there are capillaries that are called fenestrated capillaries. They contain pores, and they are going to allow for more fluid to leak out because they do have pores. These are going to be found in your kidneys, which are important because we're going to filter your blood for waste. We're also going to see that the GI villi have this. This allows for larger particles from your digestion to move into these particular capillaries. Also, the coracoid plexus, which is part of the in the brain, that allows for the formation of cerebral spinal fluid. These areas are going to have those pores to allow more fluid to go through. Again, they're going to be small. It's kind of like using a colander or a strainer when you cook pasta. The water can pass through, but the pasta cannot. And so the cells can't leave the blood, but the water or fluid can. The last group of capillaries we see are what we call the sinusoids. Sinusoids are microscopic blood vessels that are found in the liver, spleen, and bone marrow, and there's a good reason why they're found in these particular areas. Sinusoids are wider than capillaries. They're specialized in the function of these specific organs because they have bigger holes which allow for the movement of cells. In the bone marrow, we saw that white blood cells, platelets, and red blood cells were formed here, so they need to be able to enter into the bloodstream here. So these have larger holes so that they can enter. The liver and the spleen are going to be areas where we're going to break down and get rid of old red blood cells. Well, this is where they're going to pull them out of the bloodstream and recycle the parts. All right, so this is what we're talking about with sinusoids. Now, capillaries then are going to connect and form venules. These venules will then merge into larger vessels that we call veins. So if we take a look over here in this first picture that you have on the left, you're going to see that you have your arteriole. It's going to branch and form a network, and this is what we call our capillary bed, and these are the capillaries that are found here. Again, you'll notice this offers alternate routes, so if there's a blockage in the capillaries, we can still get blood to where it needs to go, and then it's going to connect with the venule, which is going to be the vein side, where we're going to return this blood back to the heart. Again, you're going to see a color change here when we're talking about this being in our tissues. Normally, arteries carry oxygen-rich blood and veins carry oxygen-poor blood back to the heart. The only difference is in the pulmonary circulation. Since we're going to be going to the lungs to drop the carbon dioxide and pick up the oxygen, those colors are reversed. Over here in this particular picture on your right-hand side are the three types of capillaries. The top picture up here shows you the continuous capillary. There's no holes, there's no pores located here. In the second picture would be, this is a fenestrated capillary. You can see it does have the holes. This is going to allow fluid to come through, but that red blood cell can't get through, okay, the tissue or through the vessel. On the other hand, you can see the sinusoid, and you can see that it has a lot larger holes, which allows for cells to be able to pass through a lot easier. So those are the three types of capillaries. All right, and then we have our veins. Veins carry blood from the tissues to your heart. So this is going to return the blood to your heart. The vein walls contain the same three layers that we saw in the arteries, but they look a little bit different. They have the tunica interna, which is the innermost layer. This is going to be endothelium plus basement membrane. But in this particular layer, there's no elastic that's present. The reason is because this is so much further away from the heart, it doesn't have high pressure at this point, and so we don't need to have that elastic there to deal with the high pressure. The next layer, the tunica media, has the circular smooth muscles, but they're much thinner than the arteries. Again, we're not going to be dealing with high pressure and the movement of the blood in that sense, and so because of that, we'll see that this layer is also a lot smaller. The tunica externa is made of collagen and some elastin, but again, it is a lot thinner than what we saw in the arteries. Another thing that you're going to notice, which we'll talk about more in a minute, is that inside of the veins, there's these little flaps or cusps that we call valves. They resemble the valves that are in the heart, and the whole point is to prevent the backflow of blood. That way, especially when we're trying to get blood from our lower extremities, like our feet and our legs, back up to our heart, we're having to fight against gravity. So these valves help prevent the blood from being pulled down by gravity and staying pulled in those areas. Now, blood pressure inside the veins is much lower than in arteries, so this is why that the walls are going to be a lot thinner and floppier than we saw in arteries. With such a low blood pressure, though, the force of gravity makes it difficult to pump the blood back up to the heart. So that structure we just talked about with the valve being present, that's to help prevent the backflow. The valve is a thin flap or cusp of the tunica interna, and it's always going to be pointing towards the heart. All right, so allow the movement of the blood to go towards the heart. Now, if we're fighting gravity all the time, how are we going to end up getting the blood back up to the heart? Well, the veins actually use some other structures to help with this. One is the contraction of skeletal muscles. It helps move the blood through the vein, and these are what we call venous return. This is why a lot of times if you've had surgery or something like that and you're going to be in bed for a while, they'll put those compression boots on you and they press on your legs to help push and so blood doesn't pool. And the reason for this is because you're not up walking and using your skeletal muscles that would normally milk and move the blood back to the heart. The booties do that for you. We also see that that sometimes these valves can be weak, and if they start to leak, these valves can lead to what we call varicose veins, and this is where the vein walls start to stretch and they can cause a problem. A lot of times individuals that develop varicose veins are very hard on their legs. They may work in an occupation where they're on their feet a lot, especially like on concrete or something like that, and so it causes them to their valves to potentially leak. It also happens as we get older. Now, vascular and venous sinuses are going to be areas where veins have very thin walls and no smooth muscle, and this is going to be more of a collection area of the blood that's then going to return it back into the venous supply or directly into the heart. Some examples of this is the superior sagittal sinus, which we saw in the brain, where this is going to then put it back into the veins to carry down towards the heart, or the coronary sinus that we saw at the back of the heart that dumps the blood back into the right atria. So in this particular picture, guys, it gives you a comparison side by side of a elastic artery, which resembles a large vein, a medium-sized vein with a muscular artery, a venule and an arterial, and then the fenestrated capillary versus a continuous capillary. Now, if you'll recall, our blood has to stay inside the vessels at all times. If it doesn't, we have internal bleeding and we have a problem. So these vessels are going to connect. We're going to see the blood leaving the heart. They're going to leave the heart through the arteries. They're going to travel to the capillaries. The capillaries are then going to connect them to the veins, which then take the blood back to the heart. So this gives you a comparison. You can also see in these pictures how they have the same layers, but these layers are going to be different in size and how large the layers are, depending on if the vessel has high pressure or low pressure. So now that we've seen the difference between arteries and veins, let's talk about how capillaries do their job of exchanging materials. The first thing we need to look at is that one of the most important ways that they get rid of the materials that the blood carries or pick up waste is through diffusion. And this is the most important. This is where substances such as oxygen and carbon dioxide, especially because they're gases, as well as glucose, amino acids, which are building blocks of proteins, and even some hormones can cross the capillary walls through simple diffusion. They don't need any help. They just move from high concentration to low concentration. Right? Simple diffusion, no help needed to do this. On the other hand, there are times that we're going to see that at the capillaries we see something called transcytosis. Transcytosis is our larger lipid-soluble molecules like the hormone insulin. It's going to have a little harder time crossing this barrier in the capillary, but it can cross the capillary walls in what we call vesicles. Okay, kind of like exocytosis that we saw in cells way back in the cell chapter in Anatomy 1. Okay, so it exits out using that whole idea of creating a vessel. Another way that we can see exchange is through what we call bulk flow. Bulk flow is a passive process in which large numbers of ions, molecules, or even particles in a fluid move together in the same direction. If you think about bulk, if you buy in bulk, if you go to like Sam's or Costco and you buy something in bulk, you're buying it in a lot larger amount than you necessarily need at one time. So in this particular case, bulk flow occurs from an area of high pressure to an area of low pressure. The pressure helps push the bulk material through in order to get it to the other side. And it continues as long as the pressure difference exists. So if we've got high pressure and low pressure, we're going to see bulk flow happen until the pressures start to equalize. Once they equalize, then we do not see bulk flow any longer. So bulk flow is more important for the regulation of the relative volumes in your blood and also the amount of fluid that's in your interstitial fluid. So fluid exchange is determined by something that we call Starling Forces. With Starling Forces, we see here that we have some kind of math equations that we're kind of looking at. Don't freak out because it looks like math up here because we're adding and subtracting things. But what I'm wanting you to see is that the filtration of fluid out through the artery side of the capillary and the reabsorption on the vein side of the capillary is very similar. So when we look at this, it's really important to look at two kind of forces. The first is hydrostatic force and the second is osmotic force. Both of these forces determine the amount of fluid that leaves the arterial end of the capillary and also how much of it gets reabsorbed at the venous end. All right, and so what we're looking at here is when you look at this next bullet that says NFP, this is your net filtration pressure. So NFP is your net filtration pressure. Now, net filtration pressure is going to equal your blood hydrostatic pressure plus your interstitial fluid osmotic pressure, and this is going to be on the artery side. Then you're going to subtract the blood colloid osmotic pressure. Okay, that's the next abbreviation. That's been added to your interstitial fluid hydrostatic pressure. Now, when we look at this, we should see that the amount that's filtered out should be the same amount that should be reabsorbed. That way we don't have a buildup of fluid in our tissues. That's what we should see here. So when we look at filtration, this is through the capillary wall to the interstitial fluid. The blood hydrostatic pressure is generated by the pumping of the heart. So the actual pressure behind the heart is going to be that pressure that pushes the fluids and the cells and that sort of thing out of the capillary. The interstitial fluid osmotic pressure in this area is very constant. It doesn't really change. And so because of that, the pressure behind the heart is going to allow for movement out of the capillary. On the other hand, you have the reabsorption side. This is from the interstitial fluid back into the capillary wall to where we can return it to the veins and ultimately back to the heart. The blood colloid osmotic pressure is due to the presence of the plasma proteins that are too large to cross the capillary. So we start to see that there is less water inside those capillaries and there's still stuff that needs to be moved. This is going to draw water from going from a high concentration to a lower concentration, so water is going to be pulled back in to the capillary. That's the reabsorption. The other factor we look at here is interstitial fluid hydrostatic pressure, and this is nearly close to zero. So it doesn't actually play much of a role in this sense unless there's a problem. The whole idea is that water is going to move from high to low, and if it has higher quantities outside of the capillary, it will start to move into the capillary. Now, filtration and reabsorption should be equal, but they're not. Okay, and if you kind of think about this, fluid is really hard to collect once we've let it go. Okay, think about like a glass on a table. When it's the fluid inside the glass is very easy to contain because the container is holding it. But let's just say you spill that cup. The water starts to spread out and it's a lot harder to collect it back. If you tried to collect it all back into the cup, would you get 100% of that back in the cup? The answer is no. And so it's harder to bring that fluid and reabsorb that fluid back. So fluid that does not not get reabsorbed enters into what we call the lymphatic vessels. And this is what we're actually going to talk about in the next chapter. The lymphatic vessels are going to reabsorb any fluid that the capillaries were not able to, and they will ultimately return it back to the blood. It just takes a little longer for it to get there. So guys, in this particular picture, it shows you how this fluid exchange works. This picture is located on page 740 in your book. So if you look over here on this side with the red, that's going to be the the arterial side. So we have the pressure that's pushing the blood out due to, or pushing the plasma out due to the heart rate at 35 millimeters of mercury. We also see, when we look at this, that the IFOP is going to be 1 millimeter of mercury. So if you do 35 plus 1, that equals obviously 36, okay, because we're using our math equation that's there. So that's the pressure that's pushing the fluid out. On the other side, though, we see we have to do the reabsorption side. For the reabsorption side, you can see that you have your blood colloid osmotic pressure, the BCOP. BCOP is 26. And then you also have your IFHP. Your IFHP is the interstitial fluid hydrostatic pressure, which is 0. So 26 plus 0 is 26, okay? So when we look at this, we can see on one side over here, we had this 35 plus 1, and then we're going to subtract the 26. So we had a net amount of 10 millimeters of mercury, in the sense millimeters of mercury pressure, of the fluid being pushed out. On the other side, the net filtration pressure is a little different, because if we look at this, the BHP is only at 16, okay, but the IFOP is still 1. Well, that's 17. Well, 17 minus 26, because we have 26 plus 0, is a negative 9. So if I take 10 and I subtract 9 from it, I don't equal 0. We still have one net amount that did not get reabsorbed. Well, that's going to be reabsorbed by the green structure that you see here, which is the lymphatic vessel. All right, so when we look at this, 90% of it's going to get reabsorbed by the capillaries, but that 1% is not. And that 1% will start to add up if we continually do not do reabsorption. So this is why the lymphatic system is present, in order to help reabsorb that 1% that gets left behind. So there's not a buildup of fluid in that tissue. All right, so now this brings us to where your blood is at any given point when we talk about blood distribution. Now, at rest, the largest portion of your blood in the system is found in your systemic veins and your venules. And if you look at this pie chart, 64% of your blood when you're at rest is found in your veins and venules. 9% are found in your pulmonary vessels, which are the blood vessels found in your lungs. 7% of your blood is found in your heart. 13% is in your arteries and your arterioles, and then 7% is in the capillaries. So when we look at this, guys, your veins kind of act as a reservoir for most of your blood. Now, this brings us to what we call hemodynamics. Hemodynamics are factors that affect your blood flow, okay, how well your blood flows through these vessels. The first thing we want to look at is blood pressure. Blood pressure is hydrostatic pressure that's exerted by blood on the walls of an artery, okay, and we are going to focus in on the walls of the artery that are coming from the left ventricle during that systole, the contraction phase, but also that distally, which is the relaxation phase of the ventricle. This is because that ventricle has the larger muscle, and it's pushing the blood to the systemic part of the body. Most of the time, we are going to use the brachial artery. So right here, that's why we put the blood pressure cuff right here on top of the arm here, okay, on the biceps. And we listen here because this is going to give us a good indication of the blood pressure. Blood pressure is going to be the flow of the blood times the resistance. What is causing it to be slowed down? Okay, what's causing that blood not to be able to move as well? Could it be vasoconstriction? Could it be a buildup of a plaque? Is it a blockage? There could be a lot of things that could affect the resistance side. So the systolic blood pressure is the force of the blood recorded during the contraction of the ventricle. The diastolic blood pressure is the force of the blood recorded during the relaxation of the ventricle. blood pressure is affected by a number of things. The first is the cardiac output. Remember, cardiac output is the stroke volume times the heart rate. So if the amount of blood that's coming through, if it's a larger amount, that's what the stroke volume is talking about. The volume is higher, blood pressure will be higher. The same thing with heart rate. If heart rate is higher, blood pressure normally will be higher. The resistance, what's causing the blood to not flow as easily? This could be friction between the blood and the wall of the vessel. The blood's going through the vessel and it could be causing friction and it's sticking. This could be due to plaques or blood clots or things like that. Also, the blood volume itself. If you're dehydrated, this could affect your blood pressure. If you've had a hemorrhage or some blood loss, it could affect your blood pressure. The viscosity of your blood. Guys, viscosity is how well blood or how well a fluid flows. Okay, so water has a very low viscosity so that it flows very easily. However, maple syrup has a very high viscosity and it doesn't flow as easily. That's why if there's only about this much maple syrup left in your container and you turn it upside down, it seems like it takes forever for it to get there. Okay, because it's stickier. It has a higher viscosity. So when we talk about viscosity, viscosity is going to be related to how many red blood cells there is in the fluid of your blood. Okay, so the higher the red blood cells and the lower the fluid, the more viscous it's going to be, and it's going to be harder for the blood to travel. Okay, if you have less red blood cells and plenty of fluid because you're hydrated, okay, it's going to flow a lot better. Okay, so that's what it's talking about with the viscosity of the blood. All right, so the next thing we want to kind of focus in on is that venous return. I told you how the veins a lot of times need that extra help against gravity to get the blood back to the heart. So with venous return, the volume of blood flowing back to the heart through the systemic veins occurs due to the pressure generated by the contractions of the heart's left ventricle. So when the heart does do its pumping, it does push it forward a little bit. However, the pressure on the vein side is a lot lower, so it's going to need some help. It gets help in a number of ways. Venous return is assisted by valves, which we talked about, the structure of the valve. The valves are always pointing towards the heart and they are preventing backflow of the blood. We also see that there's going to be a respiratory pump. This respiratory pump deals with your diaphragm, okay? So your diaphragm is the muscle that separates your thoracic cavity from your abdominal cavity. And when you take a deep breath in or any kind of breath in, the diaphragm pushes down, okay? So it pushes down, and when you breathe out, it pulls up. So as that diaphragm pulls up, it almost causes like a suction, kind of like a plunger that you use like in the toilet when you push the plunger down and then you pull it up and it sucks whatever the problem is there. It's sucking the blood up, and so that's what the respiratory pump is using. On the other hand, you have the skeletal muscle pump, which you can see in the picture over here, that when you use your calf muscle, it actually kind of milks the veins. Okay, as you contract those muscles, it milks the veins and it pushes the blood forward. It's more of like a milking type action as it pushes the blood back towards the heart. Now, how fast does the blood flow in all these different areas? That's what velocity is talking about. So when we talk about how fast the blood flow is the volume of the blood that flows through a tissue in a given period of time. So it's the amount in a certain amount of time. Now, blood flow is inversely related to the cross-sectional area of the blood vessel. Okay, so the bigger the blood vessel, the quicker or the higher the velocity is going to be. Okay, so if we look at the cross sections here, if you look at the aorta, the arteries, and the arterioles, you're going to see that it's going to have a high velocity in this chart, and then it's going to start to decrease as these vessels start to get smaller. Now, one thing to note though is this still has high velocity because of the pressure coming from the heart. All right, and so that's why it doesn't bottom out completely as we get to those smaller capillaries. So if we look here on the capillaries, you're going to see that the velocity of the blood slows down greatly because the cross-section of the vessel is very small. We really want it to slow down in the capillaries though, so that this gives it a chance to be able to drop off the nutrients and pick up the waste and not have to do it too quickly. We see then that velocity picks back up as we enter into the veins, in these larger veins like the vena cava. But you'll notice it never gets as high or as quick as what we saw in the arteries because it's getting further and further away from that left side of the pump of the heart that's got the high pressure behind it. Now, there's lots of factors that can affect your blood pressure. This is just a flow chart that kind of talks about how each area can be affected with your blood pressure. This particular chart is found on page 743 in your book. If you look kind of on this left side, you're going to see that this is going to deal mostly with cardiac output. So how cardiac output is going to affect the blood pressure. On this other side, when we look at the right side, this one's going to be looking more at the resistance side. This deals more with the systemic vasoconstriction, resistance behind the blood flow. It could also be due to the viscosity or things like that. But either way, we're going to see that blood pressure can be affected. All right, and so this flow chart just kind of gives you an idea of that. And again, it is found in your book on page 743. Now, what it controls your blood pressure, just like we saw in the last chapter, we looked at what controls your heart rate. We're going to also see here that in the cardiovascular center that's part of the medulla, it's also going to have a center that controls your blood pressure. This cardiovascular center regulates heart rate, the force of contraction, and the blood vessel diameter, which are all things that ultimately affect blood pressure. This center also receives input from baroreceptors in your blood vessel walls and the atria, of the heart, as well as receiving information from chemoreceptors if there's different chemicals located in the blood. This center also receives input from your higher brain regions like your cerebral cortex, your limbic system, and your hypothalamus. So if you're stressed out, if you're exercising, things like that, blood pressure will also be affected. Now, the output from this cardiovascular center can be through the sympathetic nervous system or the parasympathetic nervous system, depending on which side we're looking at. The sympathetic impulses is going to increase heart rate and contractibility, which will ultimately increase blood pressure. The parasympathetic impulses, on the other hand, are going to decrease heart rate, which will then decrease blood pressure. So when we look at blood pressure, again, there's a number of ways that it can be regulated. So let's look at the neural regulation of blood pressure first. The first thing we want to look at is what we call baroreceptors. Baroreceptors are stretch receptors in your blood vessel walls and atria. So what happens is as the blood comes in, and if it has a higher pressure, it's going to stretch these areas. And if it has a lower pressure, they're going to remain more normal. So there is what we call the carotid sinus reflex. This is to maintain normal blood pressure to your brain, and it's located right in here in your carotids. This is also where a lot of times when you are going to feel your heart rate and you're going to check your heart rate here, that area has those baroreceptors, and that's why you can feel it with each heartbeat, as the pressure comes through. Baroreceptors in the walls of the carotid sinuses detect increased blood pressure when they get stretched. This is a sensory input that gets sent to that cardiovascular center in the medulla. The parasympathetic motor output. So these baroreceptors are going to send the information to the cardiovascular center in the medulla. The cardiovascular center in the medulla is then going to determine what needs to be done. If it's the parasympathetic motor output from this center, it's going to decrease your heart rate, decrease the force, and do vasodilation. This will ultimately decrease your blood pressure. On the other hand, if there's less stretch, this means the blood pressure is too low. The sympathetic motor output is going to increase heart rate and force and cause vasoconstriction so that it will raise the blood pressure. And again, this is a reflex. This is something that happens without you consciously being aware that it takes place. We also see that there's what we call the aortic reflex. This maintains normal blood pressure to your general systemic circulation. So the carotid's going to be focusing more on your brain. The aortic's going to be focusing on more of the rest of your body. The baroreceptors in the wall of the aortic arch will detect whether it's being stretched enough or not at all. And the same pathway that we see with the carotid sinus reflex will take place depending on if blood pressure is too high or if blood pressure is too low. There's also hormonal regulation of blood pressure that can take place. Hormones like epinephrine, norepinephrine, antidiuretic hormone, angiotensin II, histamine, kinases, things like that. These are all different types of hormones that can be released that can increase the blood pressure. On the other hand, the atrial natriuretic peptide is the hormone that is released by the heart itself to decrease blood pressure. All right, so we have the neural regulation, but we also have the hormones that can regulate blood pressure. All right, so I have a couple of flow charts here that we want to kind of take a look at to see kind of what happens with these. These are what we call our feedback systems, which we learned way back in the beginning of Anatomy 1. When our homeostasis gets out of whack, how do we put it back into order? And these are considered negative feedback systems. So if you look at the chart, it tells you to start here. Homeostasis got disrupted by raising our blood pressure. So when we see that the blood pressure was raised, the baroreceptors get stimulated. The blood pressure is rising. So with this rising blood pressure, it's going to be sent to the cardiovascular center. So the cardiovascular center is going to decide what to do. It's going to tell the cardio inhibitor centers get stimulated, so they're going to decrease cardiac output. We see that the cardio accelerator centers are going to be inhibited so that this slows down the contraction, the velocity. The vasomotor centers are going to be inhibited so that the blood vessels undergo vasodilation. All of these things together are going to allow for homeostasis to be restored because blood pressure starts to decline and go back down. It will continue to do this until we reach our normal range and homeostasis has been reached. On the other hand, if we see that the homeostasis disruption is at falling blood pressure, the baroreceptors again are going to detect this because they're inhibited. Once they go to the cardiovascular center, they're going to talk to the vasomotor centers and they're going to stimulate them. This is going to cause vasoconstriction of the blood vessels. The cardio acceleratory centers are going to increase the contractibility of the heart. The cardio inhibitory centers will be inhibited, so that way we can increase the cardiac output. So the vasoconstriction and the increased cardio output is going to raise the blood pressure. This is going to return it back to normal, and now we're back to homeostasis. All right, so this is what we're looking at with more of a feedback system. All right, there's also going to be an area of what we call an autoregulation of blood pressure. This is going to be a local automatic adjustment of blood flow to a certain area in the body. So this isn't going to be blood pressure as a whole. This is going to be a certain area that's going to regulate the blood pressure in that one area for a short time according to its need. This might be increasing the blood pressure to the kidneys or decreasing the blood pressure to the liver or whatever it might be, but in that one particular area. In most body tissues, oxygen is the major stimulus for this autoregulation of the blood pressure. In the systemic circulation, blood vessels will dilate. They'll get bigger when the oxygen is low. This is to lower the blood pressure so that the blood spends more time there dropping off the oxygen. In the pulmonary circulation, blood vessels will constrict when O2 is low. The whole point there is to try to pick up as much oxygen as possible. However, in other areas in the lungs, if oxygen is present in higher amounts, those vessels will actually dilate to allow them to be given the chance to pick up the oxygen on that hemoglobin. Temperature may also be a stimulus for autoregulation and blood pressure. When a region of the body gets too warm, we see vasodilation take place, so the blood vessels dilate so that they can release the heat and get rid of that excessive heat. On the other hand, when a region of the body gets too cold, you see vasoconstriction, and it pulls the blood away from that area in order to hold it to the more vital organs. Okay, and we see this when you get too hot, when you're exercising or things like that, your skin will get flushed. You will radiate heat off, and that's what's happening there. On the other hand, when you're cold, what gets cold first? Your fingers, your nose, your ears, your toes. Those are things you can technically live without. They're doing vasoconstriction to pull the blood towards your internal organs, which are more important. This is also why your skin will look more pale in those particular cases, because we pulled the blood away from the skin. Now, vasoactive factors produced by white blood cells, platelets, and smooth muscle cells, these are also going to be chemicals that can change the vessel's diameter. It can either cause them to dilate or constrict depending on what's needed at the time. Some examples of these are the angiotensins, the exonoids, the prostaglandins. A lot of these do vasoactive factors in a local area, normally due to tissue damage. The whole point there is to either increase blood flow so white blood cells and platelets can get there, or decrease blood flow to stop that bleeding, okay, if they've got it more under control. So they're going to be used to help regulate in that area when tissue damage takes place. Now, this brings us to something called syncope. Syncope is known as fainting. It's a sudden temporary loss of consciousness, and it's followed by spontaneous recovery. Syncope normally, what causes this fainting spell is cerebral ischemia. Not enough blood is getting to the brain. So what happens is a lot of times the blood pressure drops so drastically to the brain that not enough oxygen gets there, and it causes the individual to faint or pass out. Now, this could be caused by a number of things. It could be caused by orthostatic hypotension. So this is going to be where the blood pressure drops. When we talk about it being orthostatic, this could be from when you're laying down in a prone position and you sit up and stand up too quickly, or if you've ever been bending down and you stand up too fast, it causes a drop in that blood pressure, and it can actually cause you to pass out. We even see tight collar can cause this. This is why in males, especially when they have a tight collar with a tie, if they start to feel lightheaded and they start to get pale, a lot of times they'll loosen that collar up. This could be because it was constricting the blood flow in the carotids and not getting enough to the brain. We also see that this could be drug induced, where the blood pressure could be affected by drugs, whether they're over-the-counter drugs, illegal drugs, or even prescription drugs, even to help with blood pressure regulation. So if we're looking here at another example of our flow chart, we see that homeostasis gets disrupted. We see that there's elevated CO2 levels in the tissue. This is going to decrease the pH, and oxygen levels in the blood and the cerebral spinal fluid are being affected. So there is a reflex response. The chemoreceptors get stimulated. So the chemoreceptors with this reflex, some of them are going to communicate with the respiratory center in the medulla oblongata, and this is going to cause the respiration rate to increase. On the other hand, these same reflex responses are going to talk to the cardiovascular center in the medulla, and these are going to cause increased cardiac output and blood pressure, and also vasoconstriction. So between the increased heart rate, increased blood pressure, and vasoconstriction, we see that there's going to start to be a decrease in the carbon dioxide level, increase in the pH and oxygen, which is going to return everything back to its normal homeostasis. So again, you can see the feedback mechanism, but in this case, you're not just using the cardiovascular center, you're also using the respiratory center of the medulla. On the other hand, if we see that homeostasis gets disrupted where blood pressure and blood volume will fall, the short-term effect, okay, so we'll follow the short-term first. This is where there's the sympathetic activation. So we're going to see that the adrenal gland is going to release hormones epinephrine and norepinephrine. This is going to increase your cardiac output, which is going to increase the blood pressure. And again, this is going to be for a short time. On the long-term side, though, we're going to see that the endocrine system with the hormones are going to also be used by the kidneys. With that renin pathway that we talked about in the hormone chapter, as well as erythropoietin to go and stimulate the formation of more red blood cells, these are going to allow you to hold on to more water, create more blood cells, which will ultimately increase the blood pressure and the blood volume and return it back to normal. It is going to take longer for this to take place. However, hopefully the short term can take care of it long enough for the long term to kick in and solve the problem. All right, so this is just giving you another example, but in this case you have a short term fix and a long term fix that are taking place at the same time. All right, so when we are talking about the whole idea of blood vessels, this means that blood has to be circulating through those vessels. This is very important. One of the main things that you have to check for in an individual that you come up to as a patient are the ABCs. Is their airway open? Are they breathing? And then do they have circulation? Well, how do you check for circulation? We're going to check with the pulse. A pulse is an expansion and elastic recoil of an artery wall with each heartbeat. Okay, and a normal pulse or resting pulse rate is between 70 and 80 beats per minute. Now, if it's above 100 beats per minute, the individual has tachycardia. If it's below 60, they have what we call bradycardia. There's a number of places that you can actually take your pulse. You can take it here at the carotid. A lot of people may take it down here, okay, when we talk about the radial artery down here. You can even do a femoral artery that's more in the groin area. That one's a little more uncomfortable if you're exercising. That's not necessarily where we're going to check your pulse, right? Okay, but there's different areas that we can check for the pulse. Now, again with blood pressure, and obviously guys, this is the third or fourth time we've talked about blood pressure, which means it's super important. Blood pressure, again, is the hydrostatic pressure exerted on the blood on the walls of the artery due to the left ventricle when it does its contraction, which is the larger number, and its relaxation, which is the smaller number. Systolic blood pressure, again, is the contraction of the ventricle, so it's the higher number. The diastolic blood pressure is the relaxation. Usually, we measure blood pressure in the left brachial artery, and we use what we call using the sphygmomanometer. This is going to allow us to be able to detect the blood pressure. Normal blood pressure in a young adult male is 120/80. However, in females, it might be a little lower as 110/70. Now, I do want to talk to you a little bit now about shock, because a lot of times problems with the cardiovascular system, like with cardiac output and even blood pressure, it can cause somebody to go into shock. Shock is when not enough oxygen and nutrients are being delivered to your body cells, and the cardiovascular center is responsible for this delivery system. Now, shock can be caused by a number of things. We can have an acute hemorrhage where there's going to be bleeding due to trauma. Maybe there's a GI bleed, part of your intestines, your stomach. There could be a hematoma or internal bleeding somewhere else. We also see there could be excessive fluid loss, like vomiting and diarrhea, sweating, dehydration, burns, or polyuria, where you're going to the bathroom constantly. There's different types of shock. You have hypovolemic shock. This is going to be where you have a low volume of blood that causes shock. Septic shock, which is normally due to an infection that's found in the blood. Anaphylactic shock, which we see accompanies normally an allergic reaction. A major problem when we have a decrease in the total blood volume, the amount of blood that's in your blood vessels, this is what we call hypovolemia, and it can cause hypovolemic shock. With a decreased cardio output, CO is cardio output, we see decreased oxygen and nutrients are being delivered to the tissues. And the body sees this as an emergency. And so because it's an emergency, it triggers the fight or flight response, the sympathetic nervous system. When it triggers the sympathetic nervous system, you're going to see some signs and symptoms that are going to start to manifest due to the shock. The first thing you'll see is a lot of times the skin will become pale, cool, and clammy. This is due to vasoconstrictions of the vessels to the skin, because we want to be able to shunt all of the blood towards your more vital organs. We also see that the tachycardia is going to take place, increased heart rate, because increased heart rate will ultimately increase cardio output for a while. The pulse becomes rapid, but it does get weak, and this is due to that vasodilation that can take place in certain areas that can decrease the cardio output. We see that the patient will start to sweating. This is a sympathetic stimulation of the sweat glands. The patient will start to have hypotension, low blood pressure. This is due to low volume. They'll start to have altered mental state if it continues due to the cerebral ischemia, because we're not getting enough blood and oxygen to the brain. You'll see decreased urine output. Anytime we have decreased blood pressure, that renin pathway and aldosterone, as well as antidiuretic hormone, is going to tell the kidneys to hold on to as much water as possible. Well, this decreases urine production. We also see that this will trigger the thirst mechanism and cause the patient to feel thirsty. It can also cause acidosis, where the kidneys aren't getting rid of the hydrogens fast enough, and so the blood starts to become more acidic. This creates a problem, because as the blood becomes more acidic, it's also harder for the blood cells to carry oxygen. It can also cause nausea. This is where decreased oxygen and nutrients to the digestive tract takes place, and the list can go on and on. But these are just some signs and symptoms of shock. So in your textbook on page 751, it kind of shows you what happens when your body goes into hypovolemic shock, how we want to try to return it back to homeostasis. You're going to notice that there's going to be a lot of organs and even systems involved here. There's receptors in the kidneys, as well as baroreceptors in that aortic arch and the carotids, which are going to determine that blood pressure is too low. We're going to see some control centers from the kidneys as well as in the brain, which are going to try to compensate for the issue, talking to the adrenal glands in the kidneys, as well as the blood vessels in the heart itself. All of these things are to hopefully restore the blood pressure and raise it and put it back to normal. Okay, but this is just showing you again a flow chart when we talk about hypovolemic shock and what's happening in the body. So guys, the next thing in your textbook that we're going to talk about is the circulatory routes. Circulatory routes are the blood vessels being organized into parallel routes that deliver blood throughout your body. All right, we see that there's systemic circulation is the largest circulation route here, and it's going to be in 3 subdivisions that we're going to kind of focus in on. You have the coronary subdivision, which is to the heart itself. It supplies oxygen and nutrients to the myocardium. You have the cerebral circulation, which supplies the oxygen and nutrients to the brain, which you can see here. And then you have the hepatic portal circulation, which is between your GI tract and your liver. And you can kind of actually see it here as well, because you can see the stomach and the liver as well as the intestines kind of outlined in these capillaries. Another circulatory route is the pulmonary circulation. You can see it here where you can see how it circulates to the 2 lungs. And then we're going to look at fetal circulation, which is not located in this particular picture. So let's look at systemic circulation first. So systemic circulation takes oxygenated blood from your left ventricle through your aorta to all parts of your body. This includes some of your lung tissue. This is not the alveoli of the lung tissue though, where a gas exchange is going to take place. This is going to be the lung tissue to where we're actually going to drop off oxygen and nutrients so the lungs can stay alive as well. This area also is going to return the deoxygenated blood back to the right atria. Now let's look at the aorta first. The aorta gets divided into 3 regions. Each region has branches. There's the ascending aorta. So as the aorta comes off the heart, you're going to have an ascending part, which means it's going to come up. This ascending part of the aorta is going to branch into your right and left coronary arteries. So there's going to be branches coming off the ascending part, which are going to service your heart itself. We then see there's the arch. Okay, so the arch of the aorta, okay, it's going to arch, and actually, if we're going to be honest, it's going to arch to the left, so it's going to go this way. There's several branches that come off here. There's a right and left carotid arteries, which are going to supply blood to the head and the neck region. There's also going to be the right and left subclavian arteries, which are going to supply the arms. So subclavian are here. So guys, if you're going to notice, especially in these chapters, way back from Anatomy 1 in those first couple of labs where you were supposed to learn certain body regions in terms like cerebral, subclavian, thoracic, things like that, they're going to come into play here when we're talking about this circulation and these different types of veins and arteries. We also see that there's the descending aorta. The aorta is going to descend down. This is situated near the vertebral body of T4 behind the heart. The thoracic aorta is the top section of the descending aorta, and it contains several branches that's going to supply blood to the thoracic tissues and organs. We then see the abdominal aorta. This is going to be the lower section that's going to pass through the diaphragm, going to the lower part of the body, and it contains many branches that supply all your abdominal organs and pelvic tissues, as well as your legs. Okay, so it'll supply blood to your legs. All right, so if you take a look here, this is kind of showing you how the blood gets distributed through the arteries. In this picture on the left, you can see the aorta coming off here and branching, and you can see it has many branches coming off to the different areas of the body. In this picture on the right, they took the heart out so that you could actually see how the aorta ascends, it arches, and then it descends down, and again, the branches coming off as well. Now, these are all going to be discussed in your textbook in what we call exhibits. In certain chapters in your book, they have exhibits, and they have like exhibits 21.A, 21.B, and so on. And it talks specifically about the blood vessels here. Take a good look at these. It has them listed in a chart, and then it has really nice diagrams and pictures like the pictures you see here to show you these different arteries in this particular case, since that's what we're talking about. So kind of take a look at those areas in your textbook. Now, deoxygenated blood is going to return to the heart through the systemic veins. These are going to drain ultimately into 3 main vessels. They're going to drain into the superior vena cava. This is going to receive blood from the veins above the diaphragm. So they're going to receive blood from your right and left subclavian veins, returning it back. Also your right and left jugular veins, which are going to return it from your head and neck. We also see the inferior vena cava, which is going to receive blood from your veins below the diaphragm. Guys, the inferior vena cava is the largest vein in your body, and it's about 1.5 inches in diameter. So if we're looking at it, it's about this big. Okay, it's 1.5 inches across in diameter. It's going to also receive a lot of blood from the right and left common iliac veins, which are going to return the blood from your legs and your abdomen. If the inferior vena cava gets compressed, it could cause problems and swelling below that point. And we actually see this during pregnancy. As the baby gets larger and larger, it starts to push on this inferior vena cava. And this is why pregnant women will start to have edema, especially swelling in their legs and feet, where they can't wear like shoes most of the time, or they have to wear flip-flops and things like that. There's a lot of swelling. It'll also cause temporary varicose veins. But again, after the baby's born, that pressure gets released and things will normally return back to normal. We also see then the coronary sinus. This will receive blood from the cardiac veins, which are then going to return everything into the right atria. So all blood is eventually going to re-enter into the right atria. Now, again, this is going to be shown in exhibits. Okay, when we look here at these pictures, they're going to be found in the exhibits. The exhibits for the arteries start on page 754. The exhibits for the veins starts on page 773. So again, you can see how the veins are going to return the blood up towards the heart. They've even shown you over here on the right side, the heart's been removed, so you can see the superior vena cava coming in as well as the inferior vena cava as it's going to be coming into the heart. Now, although I will not hold you responsible for every blood vessel shown in chapter 21, because if you look at those exhibits, they're long and there's a lot of blood vessels. You should be able to ID or determine where blood vessels are located most of the time based on their names. And this is going to be coming back from those labs from Anatomy 1 where you were supposed to learn this terminology. All right, so these are some ones you need to make sure you know. From the lower extremities, you need to know what the iliac, femoral, peritoneal artery, which is part of the lower leg, the anterior and posterior tibial, etc. Again, though, it could be the iliac vein or it could be the iliac artery. Know the difference. Remember, arteries are taking blood away from the heart, veins are bringing it back. In the upper extremity, you need to know axillary, brachial, radial, ulnar, or palmar. And then in some of the areas that deal with just the organs, you need to know what the renal artery or vein services, the gonadal, the pharynx vein, the cerebral artery, the hepatic, so on. Okay, so these are some of those that you need to make sure that you can be able to ID from chapter 21. But again, I'm not going to make you memorize all of them. So let's talk a little bit about hepatic circulation. When we look at hepatic, guys, hepatic deals with the liver. So this is going to look at hepatic portal circulation. We see that there's the hepatic portal vein. This is a vein that carries blood from the veins of the GI tract, like the pancreas, the spleen, the stomach, the intestines, and the gallbladder, and it's going to take this blood directly to the liver. You're thinking, well, why does it take it to the liver if it's a vein? Why isn't it going just straight back to the heart? Well, there is a reason. The blood in the GI tract that has absorbed all those nutrients, it's low in oxygen because it's dropped the oxygen off, but it's picked up glucose, amino acids, and fats, and it needs to go to the liver first. If you recall, the liver gets first choice of all these nutrients. Okay, so it's going to decide what nutrients need to stay in the blood and where they need to go. Many of these nutrients get stored in the liver for a later date. Others can get chemically modified before they can go into their general circulation. And remember also, the liver is going to detoxify any harmful substances that were absorbed by your GI tract to protect the rest of your body. Now, the hepatic artery is going to be the artery that carries oxygenated blood to the liver. That's the one that's going to deliver oxygen to the liver. The hepatic vein, notice that portal's not here. The hepatic vein is going to carry all the blood away from the liver into the inferior vena cava. So this is the hepatic portal circulation. All right, the next circulation we want to look at is the pulmonary circulation. The pulmonary circulation is the pulmonary vessels that are going to the lungs. These are going to function in an opposite way than what we saw earlier in the systemic. Normally we see arteries are red in color because they have oxygen, and veins are blue in color because they're deoxygenated. Okay, but in the pulmonary system, they are reversed. The right and left pulmonary arteries, they are carrying deoxygenated blood from the right ventricle of the heart to the alveoli of the lungs. they're going to drop carbon dioxide off and pick up oxygen. Now that they've picked up oxygen, the blood now has oxygen, and now it appears more of a reddish color. So the pulmonary capillaries is where this exchange is going to take place. The right and left pulmonary veins, which carry the blood back to the heart from the lungs to the left atria, are going to be red in color because they carry oxygenated blood that then is going to be distributed to the rest of the body. So the pulmonary circulation is opposite when we talk about especially coloration in diagrams than what we see in the other, because the arteries are low in oxygen and the veins are high in oxygen when we're talking about pulmonary circulation. The last type of circulation I want to talk to you about is fetal circulation. This is the circulation to the baby from the mother. So this involves the exchange of materials between a fetus and the mother. The mother's circulation must deliver oxygen and nutrients to the fetus, but it also has to eliminate waste from the fetus. The way that it does this is through a temporary organ called the placenta. The placenta is a structure which allows this exchange to take place. The placenta contains many fetal capillaries, so the fetus has a lot of capillaries located in this area that then get attached to the umbilical cord. These capillaries are in close contact with the maternal uterine blood vessels. Okay, so when we see here, we have the placenta that has the baby's capillaries, and then you have the uterus, which has the mother's capillaries. They come in close contact, but the diffusion goes between. There's no mixing of the blood here. It's just diffusion of oxygen, carbon dioxide, nutrients, and waste. So the nutrients diffuse from mom to baby, waste diffuse in reverse from baby to mom, but there's no actual mixing of blood at this point. Now, during fetal circulation, it is similar to our pulmonary circulation. The umbilical vein carries oxygenated blood from the placenta to the fetal liver and what we call the duct venosus. This is going to be where the liver again is going to process most of the stuff that comes in. However, this is oxygenated blood. The baby's lungs are not working yet because they're breathing in fluid, which is going to be low in oxygen. So because of this, these even though it's going back to the heart as a vein, it's going to carry oxygenated blood. The ductus venus carries this oxygenated blood into the inferior vena cava. It also will pick up deoxygenated blood from the lower fetal body. So there'll be a mixing of oxygenated and deoxygenated blood. Okay, so a lot of times we say oxygenated blood in a picture or a diagram looks red, deoxygenated looks blue. So when we add red and blue together, what do we get? A lot of times in the picture when we're talking about fetal circulation, it'll look purple because there's a mixture of the two. All right, oxygenated with deoxygenated. The superior vena cava and the inferior vena cava then will drain into the right atria just like it does in adults into the heart. However, there's going to be what we call foramen ovula. This is a hole or opening in the intraatrial septum. This can actually move some of the blood from the right atria to the left atria, then to the aorta, then to the systemic circulation. So it actually bypasses the lower part of the heart altogether. The rest of the blood does move from the right atria to the right ventricle through the pulmonary trunk, but then it goes into the ductus arterius, which bypasses the lungs. The ductus arterius connects the aortic arch and bypasses the fetal lungs because at this point the fetal lungs are not doing anything for the job of delivering oxygen or getting rid of carbon dioxide. The baby's practicing breathing by pulling fluid in and out, but there's no way to exchange oxygen here. At birth, when the baby's lungs, liver, and digestive systems begin to function the way that they're supposed to, the lungs start to breathe oxygen and do gas exchange. The liver starts to do more of its processing. The digestive system starts to actually start breaking down and digesting food because we're not relying on the food from the umbilical cord. These special structures like the ductus venosus, the foramen ovulae, the ductus arteriosus, they all are no longer needed, and so they scar over and they actually look like scar tissue and they're not present anymore because they're not needed. So guys, this picture shows you the fetal circulation. If you'll notice, most of the blood that runs through the fetus is a purplish color because it's a mixture of oxygenated and deoxygenated blood, right? You'll also notice that there are certain structures like the ductus arteriosus, the foramen ovulae, the ductus venus, the umbilical vein, the umbilical artery. These are all structures that will go away after the baby is born. Okay, they scar over. I mean, the umbilical vein, umbilical arteries, they scar over and become your belly button. okay, when we look at this. You'll see that you have the placenta here in the umbilical cord, and it's rich in oxygenated blood. However, when it hits the liver, we have deoxygenated blood from the lower part of the baby's body that gets mixed. So it's going to have the mixture of oxygenated and deoxygenated blood. We also see in the heart that the structure is a little different in how the blood moves, and it bypasses those lungs because they're not functional at this point. All right, so you have the picture, and then you also have the flow chart here. This particular diagram is found on page 790 in your book. All right, so now we have finished talking mostly about the cardiovascular system. And the cardiovascular system, again, with the blood, the heart, and the blood vessels, they start to decline with age. So there's some age-related changes that occur in each of these structures. So first of all, with blood, we see that there's a decreased hematocrit. You see there's a decreased amount of red blood cells. We also see that there starts to become more peripheral blockages by blood clots like a thrombosis. And there also starts to be pooling of blood in the legs. This is due to venous valve deterioration, which is actually part of the blood vessel issue. With the heart reduces its maximum cardio output. Just like any other muscle, it starts to get weaker. It changes. There's changes in the nodal and conducting cells. So a lot of times that pacemaker doesn't function like it should. There's also reduced elasticity of the cardiac fibrous skeleton. If you can think about like one of your favorite pairs of shorts that had elastic in it, when the elastic gets really old, it will stretch, but then once it's stretched, it doesn't always go back to that normal size anymore. And the same thing starts to happen here with these elastic fibers. We also see that there could be progressive arteriosclerosis, where we start to see a narrowing as we move through the heart and also the blood vessels. Replacement of damaged cardiac muscle cells by scar tissue. And scar tissue, guys, is just a filler tissue. It's not actually functional. The blood vessels themselves, we can see the arteries can become less elastic. This means pressure changes can cause aneurysms. And guys, aneurysms are when the blood vessel should kind of look like this. It should be straight on both sides. But when an aneurysm happens, it starts to bulge, where that creates a pocket. This pocket then, if it ruptures, you can bleed out very easily, especially if it's an arterial aneurysm. We also see calcium deposits can start to happen on the vessel walls. This can lead to strokes and even infarctions or heart attacks. Thrombi can form, the blood vessels can form, and these can be a bigger issue if there are plaques located within the blood vessels themselves. All right, so this completes our look at the cardiovascular system. If you have any questions or concerns, please let me know.